So today we're going to go through upper limb. It's going to be a fantastic, hopefully, session where we summarize everything you need to know. And it will start going through the upper limb. So the upper limb is your shoulder, basically to your hand. And we're going to talk about your shoulder, your arm, forearm, wrist, and then hand and fingers. But there's a lot of details that might not be in this in terms of bones of the hand, but that's just literally one image and you can search it up and that'll be fine. Okay, so we're going to consider bones, functions of the muscles. And whenever you think about muscle function, always think about origin and insertion. Think about the innervation. Think about the arterial supply and venous drainage. Whenever you're doing revision, focus on these points and it'll be solid summary. Okay, so part one, shoulder and arm. So the first part I want to talk about is the clavicle. It's a key bone, so you can kind of palpate it, touch it on yourself, kind of feel it. So it's clavicle, and it's a very sensitive bone, and it's an interesting bone because it has a lot of sites of attachments and ligaments, and those attachments, and I've put key structures or features of the clavicle bone here. So you have the trapezoid line and the subclavian groove, two key kind of features, and it's quite self-explanatory because of the name, luckily, that trapezoid line is for the trapezoid ligament and subclavian groove is for the subclavius, which is a muscle you learn about later. And it's just features. Like the thing is that you get all these names and you get overwhelmed, but it's kind of in the name, so it's quite helpful to remember. But it's just an idea to appreciate and understand rather than just memorize these names, memorize what's attached. Interestingly, this is just a fun fact that the clavicle is the first bone to actually ossify or kind of form as a bone in the embryo, but it's also the last one to finish the ossification process. Now, I put the dates and the years of when males and females actually complete that ossification. And the thing is, it's variable. So you can think that sometimes it might be susceptible to damage if it's not fully ossified. So I put a question here for you guys. So the session is here, kind of like questions. And you can see the answers because I know you guys haven't done this content yet, but it's just an idea to give you kind of a preview of what you're going to see. So there's two ligaments, and ligaments are kind of like, I kind of like to think of them as kind of like big, thick spider webs. They're kind of structural support mechanisms, and they're so beautiful because they are so simple but so strong and powerful at the same time. So there's two ligaments. You have a coracoid process of the scapula, and coracoid is kind of like claw-like. So when you search it up in the images, you'll see that coracoid is like this at the back on the scapula, right? And anchoring the coracoid process are two ligaments, which are the trapezoid ligament, which we talked about, goes on the trapezoid line of the clavicle, and then we have the conoid ligament, and together they're called the coracoclavicular ligament, which makes sense because you have the coracoid process and the clavicle. So if you think about it, coracoid process of the scapula to the clavicle is that connection, right? Yeah. Okay, so a key joint is the sternoclavicular joint. So break it down for yourself. Sternum, so sternum's like here, right? And then you have the clavicle. So sternoclavicular joint is kind of this joint that connects the sternum and the clavicle. And it's the manubrium of the sternum. So you have different parts of the sternum, which you have the manubrium, then you have the xiphisternum, and they have different names, I think, in Latin and Greek. They originate from Latin and Greek, which is manubrium is like a handle, so you have a handle, and then xiphisternum, I think it's like dagger, so you have the handle and you have the dagger, and it's kind of that idea that it looks like a little mini sword. So it's quite a cool thing when you see it in an anatomy dissection. So you have the manubrium, you have the xiphisternum, the body of the sternum, and then the little xiphisternum. So those three parts of the sternum. Then you have the clavicle connecting to the manubrium here. So you have a sternoclavicular joint. Ligaments again, and this makes sense that you kind of want to stabilize a joint to make it stable using ligaments. Imagine those webs connecting to a ligament. If you've seen the new Spider-Man movie, you understand, like it's a cool kind of thing that you have stability, and it makes sense about all these ligament names. Don't just try to memorize them, try to understand the best you can. Anterior, posterior, and then intraclavicular between the two clavicles. So you're kind of stabilizing every type of aspect of the sternoclavicular joint. Anterior, posterior, interclavicular, costoclavicular is the first rib. So you have your ribs, and then you have the first rib and clavicle. So every angle is basically covered, which is perfect because it just makes sense, because anterior, posterior, interclavicular, and then costoclavicular. So all the aspects are stabilized. Key point is what type of joint is the sternoclavicular joint. This is something all of your anatomy kind of teachers might ask you, and it's a synovial saddle joint. So that's the type of joint. But interestingly, if you move your arm like this, you can see it's kind of like a ball in a socket. It functionally acts as ball and socket. So ball and socket has high mobility, but that's why you need the ligaments for stability, right? And the function is that it serves as the only articulation between the axial and pectoral girdle. So you have the pectoral girdle bone, and then you have the axial skeleton, which is kind of like the main central portion of your skeleton. And that this sternoclavicular, which makes sense, you have this part of your skeleton, and then the pectoral girdle is all connected by this one joint. And it's the only articulation. So if they ask you what connects the axial skeleton to the pectoral girdle, you're going to say sternoclavicular joint. Okay, next slide, please. I know this is a lot of information, but I just want you to get an aspect and idea of it, okay? So the next joint is a glenohumeral joint. So we talked about sternoclavicular. Now we're moving along and we're going to the glenohumeral. So I like to think of a ball and a cap. Boom. Glenohumeral. Glenohumeral. You have the head of the humerus going into a kind of little cup, like a hat. It's quite cute, and it goes like that. And it's kind of a joint that has a lot of movement. If you move your glenohumeral joint, just do it on yourself and get some movement. Visualize it on yourself. It makes it so much easier to understand. So it allows you to realize how much mobility is in this joint. So if you have mobility, you need stability as well. And stability comes from something called the glenoid labrum. So the glenoid labrum is a cartilage cover. So if you think about this, it's that cap and kind of cup that I was talking about. You have cartilage elevated. So it feels like this. That's not really stable, but you have elevated cartilage like this, and it kind of makes a cup. So when the head of the humerus goes in, it allows for extra stability by making the cavity more convex. Because if you look at that as a joint, that kind of looks something up, that, and then if you cup it, it's more stability, isn't it? You can see that on yourself, and it makes such a big difference for the stability. The feature of the glenohumeral joint that allows it abduct is taking away, and adduct is bringing it back. The feature of abduction that allows it to be taut, so like this, is that in the axillary region of this joint, so axilla is like armpit, there's an articular capsule that bulges out, and that just allows the arm to be taut. It's not something you have to memorize. It's just something to appreciate and understand. They're not going to just ask you what allows it to happen like that. It's just something to understand and appreciate. So the ligaments stabilizing the glenohumeral joint. I keep going about ligaments and ligaments because stability is a key thing in anatomy, especially when you're talking about upper and lower limb. So you have ligaments. You have the middle superior inferior glenohumeral ligaments, the coracohumeral ligament, and coracoacromial ligament. So you have acromion, and that is the coracoid process is attached to the acromion, and then you have the coracoid process of the scapula attached to the humerus. Then you have the middle superior and inferior glenohumeral ligament. So just like before the sternoclavicular joint, you have all these ligaments going at different angles at the joint to stabilize it. So it's kind of the tension is there and it's kind of dissipated through the ligament. Where are most dislocations of the glenohumeral joint? Anteriorly. And I realized last time when I was presenting this that this makes actually a lot of sense. You have the coracohumeral and the coracoacromial process, and those two coracoid processes from the back, coracoid of the scapula, claw-like structure. You have more ligaments from the back, right? So you have more stability. So it makes sense that dislocations are from the front, anteriorly. Next slide, please. If you guys have any questions, please ask. Go ahead. So in this, does anyone have any questions? No? I'll take the silence as a no. Okay. Okay, so extrinsic muscles are basically the muscles that are outside the kind of region of interest that we're discussing, because you have the pectoralis and pectoralis major and minor muscles of the chest. They still contribute to the upper limb because they attach actually in places within the upper limb. Then you have a lot of the back muscles that contribute for abduction. So I'm not going to mention all of those muscles because that will be talked about in the chest anatomy and the back anatomy. The muscles I want to focus on is the intrinsic muscles, the muscles that are responsible for lateral and medial rotation, lateral and lateral and medial rotation of the arm. So lateral away from the midline of your anatomical position and medial towards the midline. Then you have a rotator cuff. I keep thinking about cups and like all these circular motions, and it's beautiful that everything is focused on stability. So we have a rotator cuff as well that we'll talk about. Next slide, please. Okay, so lateral and medial rotation of the shoulder. So you have deep intrinsic shoulder muscles, so deep internal, intrinsic means intrinsic to the shoulder, and deep muscles that laterally rotate the arm. This is something you can just appreciate and then memorize because it actually makes sense. Infraspinatus, so you have the spine and you have a spine, and then you have beneath the spine, infraspinatus inserts into the posterior aspect of the humerus head. So the posterior aspect, right? The teres minor inserts to the lateral border, lateral this side of the scapula. So both of these insert posteriorly, and if they're inserting posteriorly, if they contract, so if you try it on yourself, if you have a string from the back connected to your arm and it contracts, it's going to go like that because you're pulling your arm laterally. So lateral rotation. So infraspinatus teres minor, infraspinatus teres minor. Trying to memorize it myself as we go. But the deep intrinsic shoulder muscles that medially rotate the arm, where do you think they're going to be? Any takers to answer? I know you can see it, but I just want you to understand the thinking behind it. You can put it on the chat as well if you want. Okay, so the medial rotation of the arm like this will be anterior aspects of the arm. So anteriorly, you have the teres major, which wraps around the neck of the humerus on the anterior aspect of the head. So anterior. Subscapularis in the subscapular fossa, which is the anterior surface of the scapula, anterior surface of the scapula, anterior part of the humerus head. So that makes sense. If it's on the anterior part of the humerus head, it's going to cause medial rotation when it contracts. Does that make sense? Perfect. Next slide, please. Okay, so rotator cuff muscles, I want you all guys to go like this, okay? Go like that. You have 4 muscles that are key muscles, and I put the acronym SITS. Supraspinatus, infraspinatus. That's easy to remember, right? Supra, infraspinatus. Subscapularis. The thing that people always forget is teres minor. They're like, is it teres minor? Is it teres major? I can't remember. I figured out the best way to remember is supraspinatus, infraspinatus, and subscapularis. All these muscles are really small. So think about baby teres, not the big teres, teres minor. So think about teres minor. So supraspinatus, infraspinatus, teres minor, subscapularis. These 4 muscles form a circular cuff, and they kind of allow a little bit of movement and also stability around the glenohumeral joint. And that allows a movement and stability. But the idea is that this region is actually prone to injuries, and I've listed these here. So tendinosis, inflammation, and fibrosis. And because of the natures of the injury, it takes time to heal. Next slide, please. Okay, so very important consideration. These are very examinable. The first point is very examinable. Second point, not as much. But what performs the first 10 to 15 degrees of abduction? So you have abduction like this. It's kind of like a dance, isn't it? You have abduction like this. The first 10 to 15 degrees is actually done by supraspinatus, not deltoid. The rest of it is done by the powerhouse, the deltoid. So you just have to remember that. First 10 to 15 degrees of abduction is supraspinatus. They're going to ask you this so many times in the anatomy dissection room. So it's just something to be aware of. The other thing I just put is about subclavius is cushioned by, the subclavius cushions nerves and blood vessels passing through the axillary inlet, which is the armpit. And it also has another function that I've listed here. So you can read that if you want. Next slide, please. Okay, so this is really informative slide, but it actually makes a lot of sense. So you have, what are the balls apex base of axillary region? So whenever you have a region of interest, like you'll have the femoral triangle and lower region, you always need to think about the borders, maybe the apex of base and the walls. So the borders, so what the surrounding structures. If you look at your armpit, I can't see you guys looking at your armpit, but you can see me. But if you look at your armpit, just look at yourselves right now. What can you see, right? Like, what is that, right? So you have your clavicle here, you have your scapula at the back. So at the apex, you have the clavicle on top of your axillary and you have the scapula. That you can feel and you can observe on yourself. First rib, I probably wouldn't have guessed, but first rib is also, yeah, wait, why am I touching my clavicle? First rib, sorry. First rib is also on the apex of the axillary region, axilla, armpit. Base, what is going to be there? It's just this bit, the bit that's covered with skin that you're quite usually ticklish to. You can't tickle yourself because you're aware of what's happening. But when other people come to tickle you, like you feel ticklish, and that's the axillary fossa, that's the base. Anterior wall is just these chest muscles. People go gym, they get like bigger chests. You have pectoralis major and minor anteriorly to the axillary fossa because their muscles kind of go across to insert into the upper limb. Then you have the medial wall. Medial, so if it's lateral, it's medial. So you have the medial wall, which is serratus anterior, which is the muscle over here, which is the boxer muscle. If anyone asks you, what is the boxer's muscle? Just reply serratus anterior. That's a key question. But like when you go in boxing, serratus anterior is very important for the power that you get when you're doing punches. Then you have the rib cage. That makes sense. Posterior wall, you have the rotator cuff muscle subscapularis, but you also have the back muscles, teres major, latissimus dorsi. You also have the long-headed tricep brachii. This is the thing I probably wouldn't have guessed, so you could try and remember that. And then the lateral wall of the axillary kind of region, just the humerus, the bone. And that just actually makes a lot of sense because you just have the clavicle, scapula, then you have the humerus here, you have the pec muscles here, you have the chest in front, and then you have the back muscles on the posterior wall. So especially when you have multiple choice questions, this will be quite, like, as long as you understand it, it'll be easy to kind of recall that information. Next slide, please. Okay, we're going to talk about arm. So we've done the shoulder, now we're going to the arm. So, yeah. So humerus is, the humerus, the bone, is basically one of the key things of the arm, because this is forearm and that's arm. So the features of the humerus, you have a lateral and medial aspect that I want you to consider. Laterally of the humerus, you have a capitulum, and medial, you have trochlea. The way I remember this is lateral, capitulum. That's how I remember, lateral capitulum. I want you to enunciate that with me. I know I can't hear you, but I'm imagining you're doing it with me. Lateral capitulum, lateral capitulum. So basically, when you have the capitulum laterally, that articulates with the head of the radius, and you know that makes sense because capitulum is here, a lateral aspect, and it articulates with the radius, which is the bone in the forearm. And how do you remember what side is the radius and the ulna and the forearm? I do it like this. So if you go like that, that's an R, or inverted R for radius. So this side is where your radius is, and this side is your ulna. And we've already said capitulum is on the lateral side, capitulum is lateral. So that articulates with the radius, because the radius is the bone that's lateral in the forearm. Right? So medial, you have the other one, which is trochlea, medial trochlea. It articulates with the ulna. You have a fossa in the humerus that allows you to do extension, but you also have a fossa in the humerus that allows you to do full extension. And these fossas, which are like gaps, like little dips, are really important to allow you to do full extension and full flexion. So you have olecranon fossa, which houses so you have the ulna. The ulna has an olecranon process, and the humerus has an olecranon fossa to accommodate, to give space for that olecranon process. So olecranon, if you look at this, imagine an olecranon process, and you have a fossa here. Then you can extend your arm. The process goes into that fossa, and it allows you to lock in and fully extend your arm. If that wasn't there, you can't really fully extend. You can't get a full, larger range of extensive motion. The thing about the olecranon is that it's prone to fracture, and it's prone to fracture, especially because of the triceps. Triceps is the biggest muscle of your arm. Everyone's training their biceps, but they kind of neglect that triceps is, I think, like 2/3 of your muscle mass. So it's not really, don't miss the triceps, guys, when you go to the gym. So you have, the olecranon is prone to fracture because when you have like a triceps pulling on the olecranon, it can actually pull the olecranon to quite a big extent. So we have a fossa for flexion as well, and that's the coronoid fossa, and that houses the coronoid process of the ulna, and it's anterior because it makes sense because you're flexing the arm like this. So the coronoid fossa is over here. I'm just giving you a vague idea. You can look at the diagrams later, but coronoid fossa, imagine it's here. The coronoid process of the ulna sits and sits in. So you flex with me, and imagine that full flexion that's allowed because of the coronoid fossa of the humerus. You have humeral fractures. Humeral fractures are things that can frequently happen, and they can have associated damage with nerves and passing features within the arm. So the radial nerve is susceptible to damage. Then you can also have damage to the axillary and radial nerves if it's a humeral head injury, and which makes sense because axillary artery in the armpit, humeral head. Then if you have a distal humeral fracture, so this is proximal because it's closer and distal because it's further away, it risks damaging the radial nerve and artery, and typically occurs in children and the elderly. There's a question, which neck of the humerus is more likely to fracture? And you have two types of necks, the anatomical and surgical. And I just remember surgical is kind of like when you're performing surgery, so like you're cutting stuff up. So the surgical neck, of the humerus is more likely to be fractured than the anatomical head. Ligaments are back again. So ligaments act to stabilize the humerus head, and you have one ligament that is key, and that's the coracoacromial, I think I spelled that wrong, but coracoacromial ligament, and that is an attachment site for the scapula. And the thing about this ligament is that it never moves, so it just keeps the humerus head in place like a cat. So your humerus head, coracoacromial, coracoid of the scapula, and acromion, a ligament between those two places, right? So that's the humerus. Next slide, please. Okay, so this is a key thing to understand, muscles of the arm. So you have an anterior compartment, boom, posterior compartment. I've just put the key points about this. Muscular cutaneous nerve innervates the anterior compartment of the arm. Muscular cutaneous. In this compartment, so you have compartments, the anterior and posterior. Within the anterior compartment, this part of the forearm, because it's anterior in anatomical position, supplied by the muscular cutaneous nerve. And that means that biceps brachii, coracobrachialis, and brachialis, which are three muscles in the anterior aspect of the arm, are all supplied by the muscular cutaneous nerve. Posteriorly, boom, not trying to flex or anything, but you have the anconeus, a little muscle here in the elbow, and the triceps. People don't actually always consider anconeus a part of the posterior compartment of the arm, but it doesn't matter, okay? Just consider the little guy, okay? And the innervation is the radial nerve. And the radial nerve is amazing, just to let you know, because radial nerve supplies posterior arm, posterior forearm, and the back of the hand actually has no muscles. You don't have muscles on the back of the hand. All of your muscles are actually in the anterior aspect. So just remember, if you've ever forgotten that the posterior compartment is cool, it's rad, because it's supplied by the radial nerve. So it's rad, radial nerve. Boom. Next slide, please. Okay, so these are all the main points about the muscles within the anterior compartment. I want you to touch yourselves and feel it with me that you're touching the anterior aspect of your arm, so that when you're recognizing it on yourselves, you can like make a conscious neural connection and kind of activate those muscles when you're kind of going to the gym or doing anything. You can kind of like make that mind muscle connection. So anterior compartment of the forearm, you have biceps brachii. Where did the biceps brachii insert? Both of them insert into the radial tuberosity. So radial is on the lateral aspect. The function of biceps brachii, supinator and flexor of the forearm. Screwdriver action. Screwdriver action is basically hold a screwdriver, twist it like that. Twist it, twist it, twist it, twist it. When you think carefully, if you look at feel your arm, okay, I can feel my biceps tensing. And it's quite cool because biceps brachii is a key supinator, because you're giving supination. And if you do it strong enough, you can feel the kind of tension within your biceps. And then it's a flexor of the arm and forearm. Yeah. So flexion and supination. Supination, yeah. So what proportion of people, this is a niche point that you've had in your lectures or will have in your lectures, is that 10% of the population actually have a third head of biceps brachii that originates from the supermedial part of the brachialis. That's just an extra fact. It could be questioned, but it's just an aspect to be aware of. You have tendons running through the intertubercular sulcus / the bicipital groove. So intertubercular sulcus, you you have two tubercles on your humerus, and between them, intertubercular, you have a sulcus, which is a groove. It's also known as the bicipital groove. Why? Because the long head of biceps brachii goes through that bicipital groove. So it's just the idea that you should know it's the long head that goes through the intertubercular sulcus, because I've been asked that so many times by my anatomy teacher. I don't know why, but just remember that fact. What is the function of coracobrachialis? So this is a smaller muscle in the anterior compartment of your arm. I don't know why I keep writing forearm. Ignore that. Arm, we're on the arm, okay? And a coracoid process of the scapula to the anterior aspect of the arm, okay? So that's a smaller muscle, and that's literally all you have to know. The main one to be aware of is biceps brachii. Okay, next slide, please. Okay, so I'll finish posterior muscle and then I'll stop and then we can have a break. Okay, posterior muscle of compartment of the arm. So here, feel it with me, guys. So you have triceps. So that's the extensor of the forearm. It's attached here to here, imagine, and it's pulling at the elbow, boom, extension, extension, extension. So all three heads, medial, lateral, and long, insert distantly to the process of the ulna. Ulna, if it's attaching to the ulna, it's going to pull that when it contracts. It's extension. It makes sense. The long head, here's an interesting point, that it actually also inserts at the infraglenoid tubercle. So you have the glenoid, right? The infraglenoid tubercle. So it's below the glenoid and it's a tubercle there. And that's actually on the superior part of the lateral border of the scapula. So if you think about it, the triceps is here and it attaches to the lateral part of the scapula. So it actually allows adduction, which is taking back to the line, because if it's here and it's here, then it's pulling it when it contracts, because it can't be abducted, because that'll be lengthening the muscle, not contracting the muscle. And then it also allows extension of the arm at the shoulder joint. Okay, then you have a small little cute little baby muscle, the anconius. I love this guy. He's a little baby. He's underestimated. He's considered part of the posterior compartment of the arm, but it's actually found in the elbow joint. And if you think about it, lateral epicondyle and posterior part of the proximal ulna, it's like that little thing just covering the elbow joint a bit. And it's an assistive extensor, so it helps the triceps extend, and it tenses the elbow joint because it's part of the elbow. If it's on the lateral epicondyle to the posterior part of the proximal ulna, it tenses that elbow joint capsule. And it also contributes to abduction of the ulna during forearm pronation, which is supination, pronation. So that small abduction, which isn't that really important. That's a bit extra fact. Another extra interesting fact is that there's something called anconius epitrochlearis / sextus, and that's the name. And it's a muscle that's kind of present in a proportion of people in less than 25%. And some people have this muscle replaced by something called the Osborne ligament. I just put this in because these some rare names. Many people actually have neither of these features, so it's not really essential to learn, but I just put these in anyway because, you know, just in case you have niche points. So we have less than 1 minute, so we'll call that a break.